Symposium. This is going to be chaired by Dr. Shanmuga Sundar. Sir is a consultant and co-director at Magna Health Private Limited in Chennai. He's also a consultant at ESI Medical College, Chennai. He has received many awards during his MBBS, and he was also the winner of A.V. Gandhi Award for Best Clinical Acumen in 2010. He has multiple publications and he has also authored multiple chapters. Dr. Shanmuga Sundar, please take over.
Thank you very much. And now we are going to have the industry symposium sponsored by Microlab. So to deliver the first topic on the yearly intensive treatment for type 2 diabetes, we have Dr. G. Vignesh, who has done his DM endocrinology from SGPJ Lucknow, and he is now practicing at Dr. Vignesh Endocrine and Diabetes Center at Trichy, and he has received AR Set Award from Endocrine Society of India in 2013, and at present he is executive committee member of ESTN also. So over to you, Dr. Vignesh, for the talk on yearly intensive therapy on type 2 diabetes.
Good afternoon, everyone. First of all, I would like to thank the organizers for having given me this opportunity, and thank the Microlabs for sponsoring this one. So I'm just sharing my screen. Okay. So for the next 20 minutes, I will be speaking on how the yearly intensive treatment of diabetes mellitus is beneficial for the patients in both short term and long term. So my agenda would be, so what is the earlier better concept, and what is clinical inertia in managing diabetes, and what are the drawbacks of the usual conventional step-phase approach, and how can we change that by proactive management and earlier combination therapy, and I would summarize. So in diabetes mellitus, we all know it is earlier the better. So initially, the older view was like type 2 diabetes mellitus is predominantly insulin resistance and with the relative insulin deficiency. Though the current view has changed, that is predominantly a progressive insulin secreted, especially more common among this phenotype is more common among Asian with the background of insulin resistance. So coming to the etiology, so we all know in a genetically susceptible individuals, the beta cell unable to compensate the increased demand because of the insulin resistance. So at the time of diagnosis, when we see that there is a progressive decline in beta cell function, by the time the person diagnosed with diabetes, almost he has lost almost 50% of his beta cell mass. And this loss is not going to be static. It is going to be progressive over a period of years. That's why the most of the oral hypoglycemic agent lose their durability and ultimately land up with multiple oral hypoglycemic agents and eventually with insulin at some point of time. So this is the study published in 2013. That is how the beta cell volume looks in control and in diabetes mellitus. It is obviously decreased, and by the time the patient diagnosed with the impaired glucose tolerance, it is 50% gone. With type 2 diabetes mellitus, it is 60% gone. Again, it is both common for both obese and lean type 2 diabetes mellitus. So we all know it is not only the impaired insulin secretion or insulin resistance. We all know there is a factor called omniase octet. There is 8 variables which could be a decrease in insulin effect, or increased lipolysis, or increased glucose reabsorption, or decreased peripheral glucose uptake, or neurotransmitter dysfunction in brain, or increased hepatic glucose output and glucagon. These are various factors that contribute hyperglycemia. It is not only about insulin resistance or not only about impaired secretion. So when we see this curve, so the impaired insulin resistance in a type 2 diabetes mellitus, almost it is static. But what happens to the insulin levels and beta cell mass? At the time of diagnosis, there may be hyperinsulinemia because of the diabetes. But what happens with the progressive decline in beta cell function? The hyperinsulinemia settles down, and the patient will become hypoinsulinic even with oral hypoglycemic agent, and the sugar starts rising. So, and the rate of complication, it rises. Even at this time, some point of diagnosis itself, there are some patients, quite a good number of patients, they may have complications, microvascular complication at the time of diagnosis. Probably they would have started even at the time of resistant phase. And there is a progressive increase in the rate of both micro and macrovascular complication over a period of time on follow-up. So this complication was clearly what was association was shown with the DCCT trial. It was basically a type 1 diabetes trial where it was concluded like tight glycemic control does matters. Lower the HbA1c, the lesser chance of developing a microvascular complication, either retinopathy, nephropathy, neuropathy, or microalbuminuria over a period of time on follow-up. And we have the type 2 diabetes mellitus, we have the UK PDS trial, and which clearly shows there is evidence of benefit in long term with the good glucose control. In the intensive control arm, based on metformin, they found that 32% decrease in the any endpoint related diabetes and 40% decrease in the diabetes related death and almost 36% decrease in the all-cause mortality in the metformin arm. The other arm is the sulfonylurea and insulin-based arm. Still, it shows that 12% benefit in any decrease in the endpoint. So earlier glycemic control or intensive glycemic control has benefits over compared with conventional therapy. So what is legacy effect? So those patients who had initial good glycemic control with the intensive glycemic control compared with the conventional glycemic control, they have a decreased cumulative risk of progressive complications, that is long-term complications, microvascular complications. So this is a UK PDS trial. They have recruited patients, type 2 diabetic patients, around 5,000, 6,000 patients till 1997. And there are two arms. The conventional arm is the diet only arm, and intensive control arm is sulfonylurea, metformin, or insulin arm. So they have controlled these patients with the drugs for a period of till 1997, and after that they were followed these patients for a period of 10 years. So after the active treatment phase, they found that HbA1c almost remains same for the both arms, almost they emerges because they lost the difference in HbA1c when the intensive treatment is ended. But what happens is that these patients with the intensive glycemic control had a very good legacy effect. So at the end of 10 years, they could see that patient who has received intensive treatment showed 25% reduction in microvascular complication and 15% reduction in macrovascular complication, especially MI, and decrease in all-cause mortality. This is because of the hyperglycemic memory and the legacy effect. So coming to the VADT trial, this trial they have compared the long-term effect of uncontrolled diabetes or in developing complications. They have recruited patients who had uncontrolled diabetes. That is, at the time of recruitment, the most of the patients have HbA1c of 9, and they have a long history of uncontrolled diabetes as per the records. And they recruited and they divided into two arms: the conventional control arm or intensive control arm, and they followed it over a period of 7 years. And they found that almost there is no significant difference in the cardiovascular death between intensive therapy arm and the standard therapy arm. It means that it takes a long time to undo the bad legacy which the patient has gained in the initial phase of diabetes control. So earlier control is better in terms of long term, even if the patient loses the control after a period of good glycemic control for a long time, they may be protected from the adverse effects of hyperglycemia. So the earlier the better. It is most important than the achieving the lowest possible target. So what is the current status of glycemic control? All throughout the world, the statistic says there is more or less 50% of more than 50% of patients have a poor glycemic control. This is a statistics published by IDF in 2013. They estimated around 380 people with a million people with diabetes. Now the global prevalence is around 463 people in 2019. They found only 50% of patients with diagnosed diabetes, and means for every one patient type 1, type 2 diabetes diagnosed, there is one patient without having a diagnosis. And of which the patients diagnosed, of which only 50% could be able to receive a proper care, of which 50% could be able to achieve the targets, and of which only 50% could be able to achieve the desired outcome, that is prevention of long-term complications. So the actual rates of diagnosis, treatment, target, outcome vary in different countries. This is a study published by Dr. Mohan et al. There is an Indian patient. They assessed the 6,000 patients in tertiary clinic with the mean duration of diabetes of 7 years. and they found the mean HbA1c is around 9, which most of the patients are uncontrolled. And they found only 20% of patients have achieved the target HbA1c of less than 7, and almost more than 3/4 of patients still even after getting a diagnosis of diabetes, still even after consulting, even after getting medicines, they are not on good control. So unfortunately, most of the patients wasted the first 10 years of natural history when the disorder is easy to treat. It is easier to treat because they have a good beta cell mass and the sulfonylureas will work well, and the DPP4 inhibitor, which is dependent on beta cell, will work well, and it is easier to control diabetes. But it is wasted because of the clinical inertia and lack of recognition, that is lack of screening. So lack of recognition, we already saw that IDF data, there is every one case of diabetes diagnosed, there is one undiagnosed case roaming around. So there are many cases. So initial few years of golden period is missed, and when the patient present to us, they may land up first time, even at the first time of diagnosis, they may have a microvascular complication. And clinical inertia. So this is the most important thing. Inertia can be from the physician side or the patient side. The physician side, it is a failure to initiate therapy, or when the patient is on therapy, it is failure to intensify therapy in a timely manner, so that we can prevent the long-term complication. Also, a failure to establish the proper targets. Those who are on therapy, those who could not able to achieve a target, we also call it as clinical inertia. So delay is often occurs between stepping up from monotherapy to combination therapy. This is a study published in 2014, which says the patients only on metformin, it takes at least 14 months when the sugars are uncontrolled, like HbA1c of more than 8%. It takes at least 14 months to titrate to second OCD. Or in sulfonylurea only arm, so it takes at least 20 months, nearly 1.5 years to get a second agent. So what the guidelines advise, if the patient is already not controlled, uncontrolled HbA1c for more than 3 months, it is advisable to add a second agent or third agent, whichever is necessary. So this delays in initiating a second agent, what we call as clinical inertia. This is a conventional approach. It's a stepwise approach. So when the lifestyle modification fails, when the sugar shoots up, we add oral hypoglycemic agent, and which is controlled for a short period of time. Again, when the sugar shoots up, we add a second agent, and we'll wait for some more time. We'll add a third agent, and so on. So what happens is that almost half of the days the patient will be spending in the hyperglycemia, and the mean HbA1c will be more than the expected. And over a period of time, the patient will have cumulative risk of developing microvascular complications of diabetes. So what is the drawback of this step-back approach is that even short periods of hyperglycemia will increase the risk of complication. So we need a proactive approach that is required to get the patients to achieve glycemic controls earlier to prevent both micro and macrovascular complications. So this is a proactive approach. The earlier and appropriate intervention is needed. So when the patient fails, when the lifestyle modification or first oral hypoglycemic agent fails, and the sugars started rising, we need not wait for a long time. As soon as add a combination agent or titrate the agent or add a insulin as required, so that we can keep the baseline HbA1c within the target, and we can avoid long-term complications of diabetes. So what are the advantages of this therapy is that we can achieve the therapeutic goals early, and we can reduce the risk of side effects by choosing a single agent. By updating the single agent, we can, if we combine 2 or 3 agents at a medium dose, we can avoid an adverse effect of when we use it as high dose of single agent. So, and again, oral hypoglycemic agent, when you use dual agent, the mode of action may be complementary. One thing, and second thing is that, and they may have an additional beneficial effect like weight loss. For example, when metformin combined with the SGLT2 inhibitor, and which can promote weight loss in obese diabetes. So combination therapy has a potential to delay the disease progression. So when should we introduce a combination therapy? So if a patient's on a single agent or lifestyle modification and could not able to achieve the target HbA1c in 3 months, always consider combination therapy. So the risk of complication rises when the HbA1c is high. So any patient who present with high baseline HbA1c for the first time, HbA1c more than 9, If they have symptoms, always start with the insulin. If they don't have symptoms, always start with the dual agent, and then depends on the further reduction in the sugars and HbA1c, you can titrate the doses of the individual agents. So when the HbA1c is high, like more than 9, the monotherapy may be insufficient in bringing down the sugars in these. So all the guidelines, ADA, ESD, and AACE recommends to initiate a combination therapy or an insulin in all patients with HbA1c more than 9 or 10. So what is the benefit of adding second drug or a combination agent to begin with? So we can see, based on this study, we can see the patients on combination therapy could able to achieve target HbA1c well more than when the patient on only single therapy as the glyburide or metformin. This is one point. So we can achieve a target in many patients with combination therapy if they are not controlled on single drug. Again, this is a study published by an American Journal of Medicine. They have titrated the dose of metformin to maximum dose of 2,500. What they see is that there is a progressive increase in the gastrointestinal adverse effects when the metformin is titrated around 2,000 to 2,500 milligram. Usually, we use it around 1,500 to 2,000 milligram in most of our clinical follow-up patients. So when we go to the maximum dose, there is a high chance of getting a gastrointestinal side effect, in which case combination therapy will be very helpful. And again, another use of this combination therapy is that one agent will not act on all the actors in omnes octet. So, for example, if we use a metformin or triazolidinedione, it is predominantly an insulin sensitizer. It acts in the bringing down the insulin resistance. But sulfonylurea, it acts only the beta cells. So, being an insulin secretagogue, sulfonylurea and linites act at single level. So ultimately, we need to address this inadequate glucagon suppression or chronic beta cell decline. So we have newer agents, either DPP4 inhibitors or SGLT2 inhibitors, which can act at multiple levels of these pathways and bring down the sugars and delay the progression of the disease. So to begin with, always, if the metformin is an ideal oral hypoglycemic agent, it is a first choice agent because it fulfills many major criteria like it has weight loss, it is beneficial in obese patients, cardiovascular safety is proven by UKPDS trial, it is cheaper, and there is no hypoglycemia. So metformin is the first choice drug and it's the oldest gold. So what comes next after the metformin is a big question. So what does the guideline says? The ADA 2020, they said, in a patient with the high risk or established atherosclerotic cardiovascular disease, it is recommended to start a GLP-1 analog with proven benefit. If not affordable or if not tolerated, it is better to start with the SGLT inhibitor with the proven CVD benefit. If the patient had predominantly cardiac failure or a chronic kidney disease, it is preferable to start a SGLT inhibitor with the evidence of reducing heart failure. Or if SGLT2 inhibitor is not tolerated, patient can be started on GLP-1 receptor agonist. So if there is no risk factor, then the patient can be started on DPP4 inhibitor, thiazolidinedione, or sulfonylurea, or alpha glucosidase inhibitor. We have to individualize the factors. Again, this is AAC 2020. Again, the metformin is the first choice agent, but in patients with the atherosclerotic cardiovascular disease or CKD or heart failure, GLP-1 receptor antagonist or SGLT2 inhibitors has to be considered as first. Again, it says when the patient entry experience is more than 9, if they have symptoms, better to start with the insulin. Or if they don't have symptoms, still the experience is high, start with the dual therapy and then titrate. The sugars are better with the dual therapy, and patient develops hypo or a patient develops a lower HbA1c, we can down titrate to single agent. Many of the times the patient will have a glucotoxicity, they present a very high HbA1c, and once we start the drug, they will suddenly crash into very low sugars on follow-up, in which case we can down titrate the oral hypoglycemia. So what next after metformin is a big question. So already I mentioned, if it is high risk, we start either SGLT2 or GLP-1 receptor antagonist. If it is a low risk, is a therapy of choice has to be individualized. So we will see what are the agents available for combining with metformin. So most commonly used agent in our country is sulfonylurea because it has advantages. It has a long, extensive clinical experience, time-tested drug. So it is good efficacy. It can reduce HbA1c by 1 to 2%, and it is CV neutral. Probably Dr. Prem will be addressing in next talk about model sulfonylureas and cardiovascular safety. And it is cheaper. It is most important for our resource poor settings. Disadvantages is hypoglycemia and weight gain, and the problem of durability, and the problem of myocardial ischemic preconditioning that is more common with the older sulfonylureas. The next stage is a glitazone. The advantage is it is an insulin sensitizer. Obviously, it addresses the central insulin resistance, which is one of the major important pathogenic mechanism in type 2 diabetes. Beneficial effect, it has no hypoglycemia, and it is cheaper. Disadvantages, it produces edema, again it produces weight gain and risk of bone fractures in most common in postmenopausal women. Risk of heart failure, it should not be used in patients with stage class 3 or class 4 heart failure. Risk of macular edema. Again, the newer agents, DPP4 inhibitors, can be combined with metformin. So the potential advantages, there are less adverse effects, no hypoglycemia, no weight gain. They are CV neutral. There are a very good number of studies, eco study. So they are well tolerated. They have favorable adverse effect. The disadvantages, they are not very potent. They have only modest efficacy, and they're expensive. Though the recently the vildagliptin has prices has come down, and telligliptin is a cheaper alternatives available for use. So the last but not the least is the SGLT2 inhibitor. So nowadays, last 2-3 years, most of the talks we goes around the SGLT2 inhibitor because it has a lot of benefits. It produces weight loss, no hypoglycemia, BP reduction, clear CV benefit by EMPA-REG study, CANVAS study for canagliflozin, and it was CV neutral for dapagliflozin by declared trial, and it has favorable renal outcomes and recent data on reduced risk of heart failure in patients with reduced EF, especially with the DAPA-HF study. So even in non-diabetics, it is beneficial. So it is effective in all the phases of insulin. So the action is non-insulin dependent, not beta cell dependent. So it can be used at any it can be combined with any agent. It can be used at any stage of diabetes, even in insulin dependent phase. The disadvantages is more important. We need to see in a tropical country where the risk of dehydration is high, and the risk of genital infection is high when there is a dehydration, when there is a poor water intake, and the rare risk of decay. Again, the cost is expensive. So when in a resource poor country like us, we need to consider the cost before we need to discuss with the patient before they initiate such this agent. The last thing is alpha glucosidase inhibitor. So the advantage is it is effective for postprandial hyperglycemia, and there is no hypoglycemia with this drug. It is weight neutral, but disadvantage is very mild efficacious. It can bring down the HbA1c around by 0.5 to 0.7%, and it is predominantly fast postprandial, so it will not cover fasting hyperglycemia, and multiple doses are required, and it has GI side effects. So simply, we can say we always, as a physician, we think about addressing physiology, durability, efficacy, and safety, and other issues. But the patient perspective, they always think about the numbers, always think about see the numbers for glycemic control, and how easy for them to take the drugs. It's once daily or thrice daily. They think about it, and cost in our setting, in resource poor setting, the cost is a very important thing which we need to discuss with the patient before we start any agents. And side effects, when they have a severe gastrointestinal side effects, we need to switch. When they come, we need to ask in every visit, we need to switch over the agents required. So it is basically a patient-centered approach. It's basically sad decision making. We always discuss with the patient and with the best available evidence, taking into the patient preferences and values. And final decision is regarding the lifestyle choices ultimately lie with the patient. So we need to individualize the blood glucose levels for each patient. We need to focus on the needs, values, and preferences of each patient we can't push our therapeutics or push our diagnosis or our opinions on them. So we need to assess them, we need to discuss with them. We need to assess them on follow-up when they are monotherapy. If they are not uncontrolled on single agent, we need to intensify, or we need to use a combination therapy, which may be of useful in bringing down the sugars. We need to individualize the targets, so one should not fit all. So individualization based on the patient's attitude and the risk of hypoglycemia and other events, and the duration of diabetes and the life expectancy and other comorbidities. We need to individualize the targets and individualize the treatment for each patient. So summarizing, so I conclude the early and aggressive treatment for type 2 diabetes is always beneficial. The pathophysiology of type 2 diabetes is complex and it involves multiple molecular pathways in various organs. Hence, we require a multimodal approach for treating this condition. So it is a progressive decline in beta cell function. So we need to initiate treatment early and intensify with multiple agents if required. And clinical inertia in initiating agent or intensification directly impact the quality of healthcare, and it should be addressed in the early phases of diabetes. Early combination therapy with metformin in patients with a very high HbA1c at baseline will be helpful for early EC and early intensification. And we require to have a holistic multifactorial approach, not only control diabetes, also other risk factors like hypertension, lipids, obesity, or cessation of smoking, to have a better long-term outcome in terms of micro and macrovascular complications. Thank you for patient hearing.
Thank you, Vignesh, for that lucid presentation. One or two questions from my side. Then, if there are any questions from the audience, then we'll take that questions. So how do you approach in your clinical practice? Whether it's based on the whole HbA1c, like if HbA1c is more than 8 or 9, you go for the double therapy, or from the target level. For example, if the particular HbA1c target you are going to keep 6.5, then for that patient, even if HbA1c is 7.5 or 8, you will start with the combination therapy. So in your clinical practice, how will you approach?
It is a combination of both. So it depends on the level of HbA1c and depends on what the target we are keeping. For example, in an elderly individual, we keep a target of 8 or 8. With a limited life expectancy, we keep a target of 8. If the patient has HbA1c of 9, I will not be rushing in starting multiple agents. I will be starting with a single agent, which could be tolerable for him. So it's a combination of both the target HbA1c and the patient HbA1c at the time of presentation.
Any comment on this verified trial where even the newly detected diabetes with HbA1c 6.5 to 7.5, they started with double drug combination, and they've shown that the treatment failure is very less. The primary and both the secondary treatment failure is very less compared to people who are on metformin. I think they used up to 2 gram metformin in that study, but still the combination therapy showed very good this one reduced failure rate also. So based on this, whether in selected patients like the patient doesn't have any comorbid conditions, middle-aged patient, whether we can go for dual therapy even in patients with around HbA1c of 7?
So when the HbA1c is within the target range, if they are controlled with single agent, I mean, am I getting your point, right? If they are controlled with single agent, if their HbA1c is within target, I would like to continue. If they are already on multiple agents, say for example, a combination agent, if they could able to clearly achieve the HbA1c and they don't have any hypoglycemia when they are on multiple agents, I would like to continue the agents, combination agents. The only worry about
in newly detected patients, for example, some 40-year-old male, newly detected comes with HbA1c of 7.3. So he has already done lifestyle modification. Whether we'll start with only metformin or dual therapy, just based on the verified.
In which case, I would prefer to start with metformin only. Yeah, newly diagnosed patients, metformin has a potential to reduce HbA1c from around 1.5 to 2%. So again, lifestyle modification will bring down the HbA1c by 1%. So obviously, we can give the benefit of lifestyle modification and metformin and start with a single agent in this patient and follow them.
Okay. There are no questions in the chat box. I think 4 more minutes are there. So newly detected patients with very high blood glucose, many young people we are seeing coming with HbA1c of more than 10. So how will you counsel them for insulin therapy? Because we all know patient presents with asthmatic symptom, insulin therapy is ideal. But many times we do see patients coming with HbA1c of 13, 14 without any symptoms, without any asthmatic symptoms. So how will you counsel them for this, either insulin or whatever you prefer, or sulfonylureas plus metformin? How do you counsel them?
Yeah, it is very important in very clinical practice. We do see very commonly patient presenting a very high HbA1c and very high sugars. With symptoms, it is easy for us to counsel them for insulin. If they have asthmatic symptoms or significant weight loss, they themselves come with the symptoms. Easily, they get convinced with that. Maybe they may require insulin for a short time, maybe a month or a couple of months. Once the sugars are controlled with the insulin and metformin or a second agent, we can put the patient off insulin after a period of a couple of months. It's easy for us to convince the patient. But the problem is when they don't have any symptoms, when they do a health checkup and they come to the sugar of 300 or 400 and the HbA1c of more than 10, it is very difficult to counsel the patient for insulin, because starting early insulin, we can preserve the beta cell loss. So initially, there are a good number of studies to show that early intensification with insulin, when the patient presents with glucotoxicity, the HbA1c is more than 10 and the fasting sugars more than 250 or 300, early initiation of insulin, at least for a period of 3 weeks to 3 months, they will have a long-term benefit by you can preserve the beta cell mass. So obviously, I will tell all my patients, those who present first time with a high HbA1c, but symptomatic patient, it is very easy for us to convince them for insulin. But asymptomatic patient, again, it is difficult. We always give a choice of insulin, but even if they refuse, then I think if the ketones are negative, I think you can go ahead with the dual combination of them.
Okay. So one last question. So newly detected patients coming with HbA1c of say for 8 to 9. You are advising for a monotherapy or dual therapy, but patient wants to go for intermittent fasting. He doesn't want to start it on medications. So what will you tell him? Because nowadays we are facing this kind of a lot of questions like this from the patients, because the intermittent fasting kind of diet or low diet is gaining famous. So what will you advise to the patient, or how will you
It is
consult?
very common scenario. As you said, obese patient presenting with sugars, they want to go ahead only with lifestyle modification. I will tell them, let us start metformin only. So it is a non-hypoglycemic agent. Even the sugar, it won't bring down your sugars to low sugars. Even you start exercising or even you starve, it won't cause much hypoglycemia. I tell them you continue metformin for 3 months. Once you reduce your weight like 8 kilos or 10 kilos as per your diet plan, probably you can down take the metformin and you can stop it. Once the diabetes is reversible, you can stop it. And I tell them to try to convince them it is not harmful to take metformin and it won't have any side effect. I will try to convince them.
Okay. Thank you, Ignesh. Thank you for the good presentation, and we'll move on to the next topic. So to present the next topic, we have Dr. Prem Kumar, who has done his MD and DM endocrinology from PJ Chandigarh. We both did together around 2008 to 2010. And now he's practicing in Salem, and he has his own center at Salem, Diaplus Clinic. And he also is a teacher for DND students and PHFI faculty. And he organized the Trendo in 2018 in a big way in Salem. And he has a lot of publications and authored in various textbooks to his credit. Now he is going to give talk on the modern sulfonylurea and CV cardiovascular safety. Over to you, Prem.
Okay. And thank you, Dr. Sundar, for the kind words of introduction and the topic. Hope my slide is visible.
Yeah, yes.
Okay. So, a very good evening to all the delegates who have joined us in this Trendo 2020 Day 2. So I'll be talking on cardiovascular safety of newer sulfonylureas, and for the next 20 minutes, this is how we'll go. We'll look at the journey of sulfonylureas and what was the history behind sulfonylureas. We'll have a special focus on glimepiride. We'll look at its pleiotropic benefits, where the guidelines place present newer sulfonylureas, and the CV safety concern, the verdict given by Carolina trial, and its summary. So dear friends, if you look at the history of sulfonylurea, it's almost 80 years now. And this particular drug was discovered during World War II when they were looking for an effective antibiotic with a broader spectrum. And with this sulfonylurea component caused hypoglycemia and it almost took a decade for them to know its mechanism of action. And around a decade later, what they found was they had this drugs, first generation sulfonylureas in the market. And around 3 decades later, we had a second generation of sulfonylureas. And by 1995, we had the present third generation of sulfonylureas, what we call as newer sulfonylureas. By far, sulfonylureas are the most commonly prescribed drug for oral hypoglycemic drug for management of diabetes. Even some studies say that they are more commonly prescribed than metformin in certain parts, regions of the country. And it's why we have vast experience with sulfonylurea. There are many sulfonylureas available in the market, and they are time tested one with respect to efficacy, and there's no doubt about that. And when we say sulfonylureas, the conventional ones are the first and second generation sulfonylurea, which are the tolbutamide, glibenclamide, and glipizide. When we say modern sulfonylureas, we mean glimepiride, glycoside modified release, and the glipizide modified release. By duration of action, all the modern sulfonylureas act for 24 hours, and they need to be given once daily. And as all of you know, it acts on the sodium potassium ATPase channel, and it closes the channel. However, there are subtle differences by the mechanism of action. Glimepiride binds to SUR1, sulfonylurea receptor 1, and pancreatic beta cell, and it also binds to the EPAC2, whereas glycoside doesn't have any binding site to EPAC2. So there is a slight difference between the way they bind. So not all the sulfonylureas are same, and they depolarize the membrane, and they cause release of the preformed insulin molecules which were there in the vesicles. And other than sulfonylurea receptor 1, glimepiride and glibenclamide also acts on SUR2, sulfonylurea receptor 2, and this SUR2 is present on the cardiac myocytes, skeletal muscles, vascular smooth muscles, and so on. So glycoside acts only on the SUR1 receptor, whereas glibenclamide and glimepiride acts on SUR2 receptors. But there are various ways by which you can differentiate glimepiride and glibenclamide. This is how it is. Glibenclamide has got a strong affinity to SUR1 receptor, whereas glimepiride exhibits a lower binding affinity to sulfonylurea receptor. It has got a higher rate of association and dissociation, and it leads to lower inhibition of sodium potassium channel, and it leads to lower risk of hypoglycemia. So by mechanism of action and PKPD, it's different from that of glibenclamide. So the pharmacological effects of glibenclamide cannot be compared to pharmacological effects of glimepiride. And when given as a monotherapy, glimepiride reduces the A1C by 1.5%. It reduces the fasting plasma glucose by 40 milligram per deciliter, and it's as effective as metformin with respect to the A1C reduction. When you add glimepiride to other oral hypoglycemic agent, it again retains a A1C reduction of 1.6%. However, when added to insulin, you see a A1C reduction of around 0.4 to 0.5%, which is uniformly true with other oral agents too. And after metformin therapy, if you compare adding sulfonylurea versus DPP4, sulfonylureas are better with respect to A1C reduction compared to addition of DPP4 after secondary failure of metformin. And this particular molecule also has got extra pancreatic, extra glycemic benefits, what we call as pleiotropic effects. If you see, many of the sulfonylureas, the newer sulfonylureas, are known to reduce their hepatic uptake and metabolic clearance of insulin. There are many research and papers so substantiated. Similarly, they also potentiate the glucose-mediated uptake in the muscles by a post-receptor mechanism. So it's not only a secretagogue, normal secretagogue, it is also an insulin sensitizer at the level of the muscles by increasing the blood-4 translocation and also insulin glucose uptake by the post-receptor mechanism. Moreover, glimepiride has the property of increasing adiponectin secretion, which is again an insulin sensitizer. It also decreases the advanced glycation end product. It increases colony-stimulating factor. It also increases VEGF, and it also has got an antioxidant effect. By all this property, one can be assured that it also has some insulin sensitizing property. And various guidelines have placed sulfonylureas at an important position after metformin. It is considered to be one of the choice as a second line agent after metformin in the IDF. NICE actually prefers sulfonylurea over other OHs after metformin failure. ADA, ASD, and other guidelines from China, South America, Japan, and Korea also recommend sulfonylurea after metformin failure. However, there are a lot of controversies which surrounds this particular molecule, and these are few of them. That it can cause beta cell exhaustion, it has got lesser durability, it causes a significant weight gain and a significant hypoglycemia, and it will worsen the CV outcome. Let's look at some of them. So there are in vivo studies to show that when glibenclamide was used in culture media of beta cells, it leads to increased beta cell apoptosis. However, if you look in the clinical studies, among all the available sulfonylureas, the newer sulfonylureas, especially glycoside, glycoside has got the lesser rate of secondary failure. And the same property is also seen with glimepiride in this large cohort of 20,000 odd patients. When glimepiride was compared with DP4 inhibitors as an add-on therapy to metformin, glimepiride initiated patient had a lesser necessity for being put on insulin, and it showed a durability of more than 5 years, much ahead of DP4 inhibitors. Moreover, there are a lot of studies to show that, clinical studies to show that glibenclamide preserves beta cell. In this particular elegant study, when they compared exenatide, sitagliptin, and glimepiride, and they looked at the beta cell sensitivity index after a period of 6 months, what was seen was, compared to exenatide, which we usually believe that it protects the beta cells, glimepiride actually increased the HOMA-B better than way ahead of the GLP-1 analog and also the sitagliptin. Now we know that beta cell apoptosis doesn't occur in diabetes. What actually occurs is whenever there is glucotoxicity and lipotoxicity, there is de-differentiation of beta cells. And when they are taken care and then a normal metabolic milieu persists, then they re-differentiate into beta cells. So initially they de-differentiate to either alpha cells or delta cells, somatostatin producing cells. And when you give insulin and reduce the glucotoxicity, the sulfonylurea sensitivity comes back. And it's time again studied in various articles, and we have good data to believe that. So there is a re-established sensitivity to sulfonylurea once you take care of the glucotoxicity. And regarding the weight gain is an important factor with conventional sulfonylureas like glibenclamide, where they averagely lead to a weight gain of 1.5 to 2 kgs, and it's a maximum when it's used along with insulin. Whereas if you look at the advanced study, glycoside was weight neutral. And this is another data, 5-year data on the weight gain effect of the glimepiride. And as you can see, it is also weight neutral on the long run. Initial 1 year, you can see some weight gain. Later on, it flattens, and many of them, it goes back to the original level. Then about hypoglycemia. So if you look at the occurrence of hypoglycemia in this particular large population-based cohort study, whenever it was given, whenever sulfonylureas were given to people with a lower GFR, glimepiride had the least hypoglycemic potential compared to other available sulfonylureas. And the reason for that is it has got a lower binding affinity, it has got a higher exchange rate binding and coming out of the beta cells more frequently than other sulfonylureas, and the amount of insulin secreted with glimepiride by closing the sodium potassium ATPase is lesser compared to the other sulfonylureas. What about complications? You know that in Wikipedia, glibenclamide was one of the drug in the intensive treatment arm. It's not what drug you use matters, it's how much HbA1c you reduce matters. With 1% reduction in the A1C, you tend to see an average of 30% reduction in the microvascular complication in the UKPDS trial. And it was true with metformin, and it was true with insulin in the intensive treatment group. In the advanced study, which extensively used glycoside modified release, what they found was a reduction in the microvascular complication, especially the albuminuria was reduced, and it was nephroprotective. If you look at the VADT follow-up study, where glimepiride was used in majority of the patients in the VADT trial in the follow-up, there was a further reduction in the microvascular complication, retinopathy and neuropathy, and there was also a 17% relative risk reduction in the CV events. So here you see, because of the better A1C reduction and the higher efficacy, you get the microvascular complication reduced. So now the topic for discussion is the macrovascular complication, the CV safety of this particular molecule. A huge doubt was shadowed on this particular molecule as early almost 40 years before, when this particular study called as UGDP, University Group Diabetes Program, was published. In this particular study, they used two molecules which we no longer use. One molecule was tolbutamide, the other molecule was fenformin, and they were used in patients with poorly controlled diabetes, and they did an intensive treatment with these two molecules. And what they found was tolbutamide exposed people had a higher occurrence of CV events. And it created a lot of ripples in the field of diabetes, and a lot of controversies happened, and a lot of people thought that it will increase the CV events. And there were many small studies, small randomized control trials, many database related retrospective analysis, and also the registry based studies, observational based studies, and they looked into the CV safety of this particular molecule sulfonylureas together. And what they found was, in most of the studies, they compared it with metformin. You know that metformin is CV protective. In the UKPDS trial, it was the only molecule which reduced the macrovascular complications, whereas insulin and sulfonylurea didn't lead to reduction in the macros. So most of the studies compared sulfonylurea with metformin. Metformin reducing the CV events actually is not a good comparator to analyze the CV safety of sulfonylurea. That is my point. So if you use metformin reduces CV events, and you use sulfonylurea, it is neutral. But what the results will say is it is CV. I mean, it is a CV event because metformin is protective. That's what happened, and they create a lot of confusion because all these studies were inconclusive. Some were showing neutral, some were showing it increases the CV events. And none of them were powered to give a verdict that it increases the CV event outcomes. So what was the need of that time is a well-controlled trial which has an active comparator which is CV neutral to study the effect. But no pharma company was ready to take up because it was already in the market for the past 70 years. So and moreover, this phenomenon of ischemic preconditioning, which Dr. Vignesh was alluding to, the sodium potassium ATPase in the cardiac myocyte has an important role. Whenever there is ischemia, total occlusion, it actually opens and it causes a reduction in the generation of ROS. It reduces the inflammation, it improves the vasodilatation, and it reduces the oxygen demand in the ischemic penumbra. Thereby, it prevents arrhythmias happening and it reduces the infarct size. Whenever we block the sodium potassium ATPase channel which is done by SERT2, you actually prevent this beneficial effect of ischemic precondition. By abolishing that, you end up having a higher CV events, or the outcome will be worse. And that's why glibenclamide use reduced because it acts on the SERT2. What about glimepiride, which also acts on the SERT2? This is a wonderful paper which was published a few years back. And what they did was they took patients with patient volunteers, and they did an angiography. They put a catheter and they went into the coronaries. They dilated the coronary balloon and they caused ischemia. Then they gave IV glimepiride and to one group, and they gave IV glibenclamide to one group, and they did a intracoronary ECG. And what they found was the ischemic preconditioning was blunted when the patients were given glibenclamide, whereas it was not modified when the intracoronary ECG was not modified when the intravenous glimepiride was given. So this is a proof of evidence that glimepiride, though it acts on SERT2, because of its low binding affinity to SERT2, it will not abolish ischemic preconditioning whenever there is ischemia. And there are many observational studies when hospital patients are admitted. Those who received glimepiride before admission had a better hospital inpatient outcome compared to those who received glibenclamide. And there are many observation trials showing that mortality of patients who received glimepiride is lesser than those who received glibenclamide. But what the need of the hour was an well-designed CV outcome trial, large trial, which compared not with metformin but a CV neutral drug. So this particular trials, Carolina trial, became a verdict for the CV outcome, CV benefit of neutrality of glimepiride. In Carolina trial, as you know that there were 6,000 patients, it was the longest CV outcome trial, and there are two groups. One group, received linagliptin 5 milligram. The other group received glimepiride 1 to 4 milligram, and A1C was maintained at the same rate, and it was carried on for a period of 6.2 years. One third of them had underlying pre-existing CVD. One third of them also had 2 or more CV risk factors, and it almost matched the common garden variety of diabetes what we see. And they had adequate events at the end of the study period. And what was found was initially with the glimepiride, the A1C reduction was lesser compared to linagliptin at 16 weeks. Later on, the A1C was similar between the linagliptin arm and the glimepiride arm at the end of the study. And change in body weight. At 82 weeks, yes, there was an increase in 1 kg with glimepiride arm, unlike linagliptin arm. However, at the end of 6 years, the weight difference between the two arms was the same. So it means that glimepiride was weight neutral at the end of 6 years. And here comes the 3-point maze. Glimepiride was similar with respect to linagliptin for the 3-point maze. It was non-inferior to linagliptin. We know that other DP4 inhibitor were already compared with placebo, and they were CV neutral. So it has to be taken that glimepiride is CV neutral. And time to first occurrence 4-point maze. They also looked at hospitalization for unstable angina. Again, the 4-point maze was non-inferior to linagliptin. And all-cause mortality was also similar with the glimepiride compared to linagliptin. So these are the key take-home points from Carolina trial. It answered a major question of clinical importance whether glimepiride is CV safe or not. Yes, it is CV safe because in this well-diagnosed and long CV outcome trial, despite more hypoglycemia, there was no increase in CV events. Moreover, one should know that in this Carolina trial, the entry A1C was only 7.2. We usually don't initiate 4 milligram glimepiride when the HbA1c is 7.2, but in this trial, they initiated with 1 milligram, and they ended up giving 4 milligram even with the A1c less than 7. So by giving such dose to a patient who already has got a good control, hypoglycemia will happen. Even on top of increased hypoglycemia, because of very tight control, there was no increase in CV events. That's a good thing. So hypoglycemia with glimepiride will not lead to increased CV events. And the risk for hospitalization for heart failure was also similar. So again, clinicians should be reassured about the CV safety of this modern sulfonylurea glimepiride. At least for this particular molecule, now the doubt has been cleared. It is cardiovascular safe. So summarize, here is a molecule which has gotten a robust evidence for its efficacy, for its safety, has got less hypoglycemia potential compared to other sulfonylureas, and it's CV safe, and it's weight neutral in the long run, and it's also cost effective. So we should choose it for an appropriate patient without any doubt that it will worsen the cardiovascular events. With this, I end my talk, and thanks for your patient hearing. Thank you.
Thank you, Prem. Thank you for that wonderful presentation. And the first question is, practically, how will you choose a molecule like glimepiride or glycoside or glipizide? This is what we routinely use, this mostly this 3 sulfonylureas. So any clinical pointer to say that this patients, in this particular patients, you prefer glycoside over glimepiride or glimepiride over glycoside? And also in CKD, what will be your approach of using sulfonylureas in patients with CKD who are not on hemodialysis and on hemodialysis?
Okay, a good question. So the choice for which sulfonylurea to be preferred actually depends upon the prescribing doctor. See, glimepiride is marketed widely, and there are so many preparations available to various combination with metformin. If you look at the efficacy, glimepiride also has the similar efficacy with glycoside, but there is no any head-to-head trial between glimepiride and glycoside. But so uniformly, all the sulfonylureas has got the same HbA1c, right? The reduction. The efficacy will be same. It will be the availability first and its combination with other drugs. like with metformin, with voglibose. So that makes it made to be used in larger groups of people. Glycoside is good because titration is easy. You have 30 milligram, you have 60 milligram, you can break it and give. And to patients there are good evidence with glycoside and with Ramadan fasting. Having said that, there is also, and also in the elderly, there is good studies on glycoside, but there is also studies on glimepiride also. So it depends upon the choice when you want to use this particular molecule. So if I would like to use it in elderly glycoside, in patients, as you told, renal failure, it can be used. And glimepiride, more than 2 milligram, if you use, there is increased hypoglycemia. And because of the predominant hepatic clearance, glycoside can be used in patients with renal failure, even in patients with ESRD. Having said that, when the GFR is less than 30, I will choose insulin more than glycoside as to be a safer option, because there are studies showing that even if you use glycoside in CKD patient ESRD, the hyperglycemia is more, and but they're not well studied actually. So insulin will be a better option. Yes, we can use glycoside, and glycoside can be used once daily. Similarly, glimepiride can be used once daily. CKD in elderly and in Ramadan fasting, glycoside can be used. And nowadays, glycoside is used as 1 gram metformin also, because that was before, initially that was a difficulty in titration. So that is also available now. So both are equally efficacious.
So there is one question from the audience.
Mm-hmm.
So what about the pancreatic beta cells burning out in the long run due to prolonged use of glimepiride or sulfonylurea?
Yeah. So in my presentation, I told it's not no more burning out, it's actually de-differentiation. People have told that if you give adequately take care of hyperglycemia and you reduce the lipotoxicity, glucotoxicity, the de-differentiation into alpha cells and delta cells will reverse. It is well known. Even with the diet, people have found that by giving a diet properly, calorie deprived diet, and if you lose weight loss, all the inflammatory markers comes down. There is a lot of type 2 diabetes is a state of inflammation at the level of the liver, at the level of the muscle, at the level of the beta cells. There is IL-1 beta related inflammation. Yesterday there was a talk on it. So by modifying the diet and by giving a good glycemic control, and by preferentially by using insulin when the hyperglycemia is very reduced, there are chances that the redifferentiate happen. And people have found initially you give glimepiride, the efficacy is not there. You give insulin for a short period of time and take care of the glucotoxicity, and you reintroduce sulfonylurea, the sensitivity to the sulfonylurea is re-established. It's a well-studied phenomenon. So sulfonylurea doesn't lead to exhaustion or apoptosis of beta cells. It is only the de-differentiation power of glucose control, and it's true with other drugs too. And I showed a study where the small study though cannot be taken as a very strong evidence, where they looked at the beta cell indices. They compared GLP-1 analog, sitagliptin, and the glimepiride. Here, there is a preservation of beta cells.
Okay. The next question: how will you choose your second line of this one therapy after metformin? So now we have the DP4 inhibitors, SGLT2 inhibitors, which are almost we have the cost also almost same as the sulfonylureas nowadays. We have data after this Carolina trial that glimepiride is also a cardiovascular neutral drug. So in the clinical practice, how will you choose your second line of drug after metformin? Based on what parameters you will choose the drugs?
Yeah. So now you rightly discussed about the verified trial, and I do use a combination early intensive treatment. And for early intensive treatment, we don't have evidence with the metformin and sulfonylurea combination. Right. So I would like to, when it comes to early intensification and HbA1c is just 7.5 and want to give a good durable effect for a prolonged period of time, then I will choose a fixed dose combination of the metformin with a DP4 inhibitors. Okay. And glimepiride is good because the titration is good. An elderly patient comes, you start with the postprandial glucose is just above 200, where you keep 200, not 180 in them. We can start with 0.5 milligram. We go to 1 milligram because 1 milligram they develop hypoglycemia. DP4 inhibitors also lead to hypoglycemia. One must when given along with metformin. So in such scenarios, it's good. And moreover, if you look at the efficacy, sulfonylureas are more efficacious than DP4 inhibitor when patient has got a poor glycemia. Now the A1C is above 8.5 or 9, and you use sulfonylurea, and the other group you use a D4 inhibitor, the A1C reduction is better with sulfonylurea. And there are, now I showed on data also. clear better. So the time left for initiating insulin is lesser, it is more for sulfonylurea compared to DP4 inhibitors. Again, it's a choice. Now that we know it's safe, so it depends upon what drug you want to, what is available, the affordability of the patient. If the patient is goes to office and the diet is not fixed, he takes lunch late, DP4 inhibitors are the best choice, like bank employee, teachers, and that thing. Because there is a hypoglycemic component which cannot be neglected, which cannot be forgotten. It is there with sulfonylurea. There, DP4 inhibitors plus metformin has an important role to play.
Okay, as you spoke on these cardiovascular issues, in post-acute coronary syndrome patients, where we are worried about the patient should not go into hypoglycemia also. Whether you start the patient on sulfonylureas or just put the patient on metformin plus or minus other drug or plus or minus insulin.
Okay.
How confident will you be starting the sulfonylureas?
Inpatient management.
Or immediately at the discharge also, at the time of discharge?
Yeah, I look at the HbA1c of the patient. If the patient is already on a sulfonylurea and his HbA1c at the time of admission less than 7, I'll continue the same drug. And I'll add on a SGLT2 inhibitor. I'll reduce the dose of sulfonylurea. If it is a glimepiride, instead of 4 mg, I'll put him on 2 mg. If the patient is not having a A1C above 7 and at the time of admission, at the time of discharge, if the patient is not on only metformin, I will prefer a SGLT2 inhibitor to be put because of its immediate effect. If you look at the CV outcome trial, as early as 12 weeks, you see the CV benefits. So I'll definitely start SGLT2 inhibitors before considering sulfonylurea. And during IP care, if insulin was started, I will not stop it abruptly. I'll reduce the dose. I'll add on SGLT2 inhibitors. In the next visit, I'll titrate the insulin dose.
Okay. One last question from the audience. Whether you use prefer glimepiride to use as a OD dose or a twice a day dose?
So it's a good question. When used as a single drug, it has to be given once daily. Now we have with metformin, we have 3 and 4 mg available as fourth combination. So it depends upon the thing. If you give 4 mg and if the fasting glucose is not well under control, we might use. Sometimes we have oglypose fixed dose combination, which is available with only the upper limit of 2 mg. So to reduce the pill burden, I use it once daily. And if the fasting plasma glucose is well not controlled, though it's not logically looks right and with respect to scientific evidences, but if you give a smaller dose in night, yes, the fasting glucose gets controlled. If there is nocturnal hypoglycemia, I reduce the dose or make it 3 mg daily. It depends upon the patient, individual patient response.
So mostly you prefer once a day dose rather than twice a day dose.
Yeah.
Okay. Thanks, Prem. Thanks for that wonderful presentation and also for the nice discussion. So thanks everyone for joining